Hi, I'm Shanna. If you're new to the channel, I'm a Canadian medical student. Every Wednesday, I release short videos with interviews with different medical students, such as today, advice for pre-meds or new medical students, day in the life vlog. Subscribe to not miss the variety of amazing medical students that I will be talking about. So today, I'm super happy to be introducing my classmate, Brandon. Brandon and I are in the same small group together, so we know each other quite well. Brandon has an interest in pathology. There's a lot of different ways to study for medical school, and there is no right answer. Number one, because every single person is different. What works for one person is not going to work for the other. I like to think that every study style is helpful. It has its benefits, it has its cons. So even if you are all the same person, if you took any of the styles of learning and studying, you still would succeed. So, but I do think it's important to just talk to different people, interview people like Brandon and other people, and just offer a whole bunch of options to know about so that people have different things to pick from, or if they don't want to take the whole study system, they can just pick aspects that speak to them. So without further ado, Brandon, how do you study for medical school? What did you find that didn't work, and now that you found works? You can start with histology. So histology is this class that many medical students really struggle with because most people never had exposure to. So it's kind of looking at slides where they show different cells and tissues.
Just to answer this question, I'm going to go a little bit to the abstract, and then I'll tell you exactly what it is that I do now. During my musical training, actually, there's a lot of you spend a lot of time going over music scores by other composers, and you read them, you analyze them, you sort of are looking at many dots on a page, right, and figuring out what the language of the composer, just visually, not even listening to them, is trying to tell you. And that can be very simple things like density of notes, how many instruments are playing at the same time, how loud the music is, these sort of characteristics that you see an imprint of that aren't actually the actual real thing, because you're not making sound when you're reading a music score. You're imagining sort of what you're seeing is implying. And for me, in terms of pathology review or histopathology review, I take a very similar approach to that. So it means that you kind of systematically look through various aspects of a tissue or whatever they give you on a slide for histopathology, and kind of just learn the basic units of what's happening. And then from that, you can learn what's going wrong. A year and a half ago, what's the best way to study histology? I would say it's pattern recognition. And I think you can do okay with that, at least as a medical student. But looking clinically into how things work now, I've signed up for several several pages that send me a case of the day in pathology or radiology, and you kind of expand things that way. That pattern recognition really isn't the only thing that you have to learn for this, because, for instance, if you memorize the appearance of 100 different diagnoses through histology, if somebody throws you 101st pathology and you don't know what it is, first step is to be able to do a pattern recognition, and the second step is to be able to understand the deeper cause for the structures that you see. This structure-function relationship, the way that I do that, Anki software, which basically allows you to flip through flashcards and look at various images or various text or whatever. And so basically that's what we do, is we have lab handouts for histology, and I take one or two pictures of each thing that they cover off the server, the website for histology, and I add those to my cards. And then I'll either type up a description underneath, or I will have a look at what's in the lab manual and copy an image of what's in the lab manual. How they assess us for that, that's basically all we have to do in first year and second year medicine, right? To expand upon that in third year and fourth year, where they might give you a case you've never seen before and you have to decide what's going wrong, that's a completely different story. And I actually kind of haven't reached that part in my training yet, other than realizing that it's necessary. So I think maybe what I do know, right, is to know what's normal and to be able to identify what's normal about these structures. And then when things are abnormal, you can communicate that to somebody who might be able to help you out. You can say this cell nucleus looks abnormal, or this basement membrane looks abnormal. And then you can reason it out that way.
How did you study for other classes? So maybe like our main content.
Beginning of first year medicine, I had a lot of difficulty with the transition in between typical undergrad science education and medical school. And they're very different in a lot of ways. So basically what I would do is I would learn everything like a science, like an undergrad science curriculum, and I'd memorize the details, and, was kind of sobered and shocked when things didn't turn out the way I wanted them to that December. There's a couple approaches. So the first thing is to realize that everybody who teaches us things has a different background. Some of them are research scientists, some of them are specialists, some of them are in general medicine, some of them have clinical experience, some of them mainly work out of a lab. And to kind of realize not only the content, but also who it's delivered from and what their research focus is. That sort of is very important in terms of understanding what's important to know for an exam, for instance, because you can't know all the material in medical school. It's just not possible. And it's also true that you're not going to use all that material for your career, right? So that's the first thing is sort of to understand where your sources of information are, where to look if you don't know something, which includes many resources such as BMJ best practice, or UptoDate is a very common one, or just being very good at doing scholarly research and finding published articles, and to realize the context of what's important to know for you, which may be very different from what's important for the person next to you in med school. The other important thing is to find a way to kind of systematize your information, so that when in third year or even in late second year, somebody shows up and they're presenting with something that you can't miss, you can look it up very quickly and you know where to find it. So for me, that looks like I'm known for using Excel, but together sort of a Cole's Notes version of what we're learning in class. And that does two things, I think, that are really important. One, I can find information very quickly from very early on in the education, which is great. And it's not always the most detailed information, but I know that it's something that's been covered before, right? The other thing is med school is sort of like an all-you-can-eat buffet. So before medicine is more like a course meal where, they give everybody the same information and you have to know it really inside out and backwards, and then you're examined on it, and that's how it works. In med school, I'm not sure if you find it the same way. I'm thinking many of us do, but you're welcome to tell me if you don't find it this way. That it's sort of like drinking from a fire hose, in the sense that you have so many options and you have so much information that's getting given, that's being thrown at you. There will be scenarios where you learn one thing and then you learn another thing that only partially applies to it, or sometimes even directly contradicts it under certain circumstances, or this kind of stuff where things might apply in one case but not the other. For instance, we had a week in quite early on diabetes, right? And the requirements for cholesterol in diabetes. And we were given a specific number for LDL in that scenario. And so I took that to mean that, well, in all cases of any vascular disease, this is what the LDL cutoff is. And now, having spent some time clinically, I realized that's not true. There's a whole Framingham study that's associated with, what other risk factors do you have? Do you have kidney disease? Do you have a history of heart disease? Any previous MI? This kind of stuff will all have an effect on what the target cholesterol is for you, right? So, this is an example of things where there are certain aspects which are true in a certain situation, but not always. And what creating this or tabulating this information allows me to do is I will have columns that are associated with every part of a visit from the beginning to the end. So the basic pathophysiology of a disease to how it shows up. So what will a patient look like in your clinic when they may have the disease, to how do you physically examine them, to what questions do you take on their history. Those are two are switched actually. It's usually history, then physical, right? To how do you diagnose the disease, which sometimes is clinical and sometimes actually isn't. Sometimes it has to do with just a kind of a gestalt feeling of what's been happening in the history. And then how do you treat it, and any other complications or any other information that's important. And the neat thing about that is if something applies in a certain situation only, then I can actually look at that cell on my spreadsheet and say, wait, this person or this particular situation, this is what I learned. And that kind of contradicts from what I'm learning now. And I can immediately see, the need to refine whatever the information is there. And it is sort of having a database allows me to do that really well. Otherwise, I'm constantly flipping back on notes that I may have had a long time ago and trying to edit those. And it can be a really long time to search for a certain slide or a certain page where you read something.
Well, when you make those, are you making those, like, say, at the end of the day after we've had 4 lectures, are you making those as you go, or you make them as we finish the term, or when do you make these?
Yeah, this kind of goes back to the paperwork question that we were talking about before, when I, get home at the end of the day and do what I'm supposed to finish doing. And some days in med school are so overwhelming that you can't even finish them until the weekend, just with the amount of content. But what I usually do, actually, it's changed a bit and it's evolved a bit over the last 2 years. But what my normal routine now looks like is I type in the stuff that I remember just from the lecture without looking back at the notes first. So my general information during the week that has really stuck out and kind of been very salient for me, I type that right in immediately. So it's off the top of my head, right? That's a lot faster than flipping through slides and typing through everything, which I think is kind of inefficient. And then after that, what I do is I go through the slides and I make quick revisions sort of to things that need to be added or things that need to be clarified. And so there's a kind of a 2-step process. One, I'm taking the stuff from the top of my mind and I'm sort of, I'm doing a very quick sort of dictation onto the table of the stuff that we learned that week. And then after that, I go back and realize areas where I may have missed something, areas where I forgot some important number or some important guideline, and I enter that in a different font a lot of the time now too, so I can see the areas where maybe I didn't realize something or I wasn't so clear. So
you mark the stuff that you recalled straight from memory, different from the ones that you just didn't remember and you had to pull out. I try to.
And then there's one third layer on that, which is really, really important stuff that you can't miss. Right. So certain emergency cases, for instance, where you cannot miss them, that's really important stuff. And sometimes I'll write that in a different font or a bigger font, or I'll color it red or whatever. Color coding is useful in a lot of ways. So that's basically, it's a 2-step process. First, you dictate what you know, then you find out what you didn't know. And then when it comes down to exam time, all of this stuff is very clear. And the other thing that I find is helpful about this is sometimes this is more of a pathology radiology thing where differential diagnosis is really important, where there's certain diseases that will mimic others, and except for one very important aspect in the disease. For instance, type 1 versus type 2 diabetes, they have a different age of onset, they have a different presentation a lot of the time. Your patient will look different a lot of the time. The history in terms of vascular risk factors will look different a lot of the time. So in this kind of setup, I can see immediately vertically the relationship between the two diseases and sort of piece together a compare and contrast of, okay, so if somebody shows up with symptoms that are common to the two of them, how do you elucidate whether or not they have disease A versus disease B?
I think that's helpful because that's very practical minded. So how would you review the review tables?
It depends on what kind of exam it is, right? So for us, we have multiple choice exams mainly. I will just review what I've written down again. And if there's something where there's a gap, then I address that. We're also given practice questions. So I go through the practice questions and I immediately correct those. If there's something that's missing in the table, I add it. Mm-hmm. And it is a bit of a, come to think of it, for first and second year medicine, it's great. For third and fourth year medicine, where you have to think a bit more flexibly, it might be a bit different. So it's still under progress, this method that I
use. First and second year. At least, at least, we don't know how third, fourth year works, but hopefully maybe will help someone who likes to think in a table comparison format as they go into first year.
I guess the bottom line is you can't really go particularly wrong realizing what a certain pathology looks like and how it's different from other pathologies.
Mm-hmm. Normal, abnormal. I think that's the whole basis of medicine, honestly.
Yeah.
Same with clinical skills too. Like, what is normal like? What is some sort of abnormal like? But you don't even have to know all the abnormals, as long as you know a solid grasp on what normal looks like.
Yeah, very true. And especially in pathology and radiology, things where you can't really tell in the beginning whether something's normal or abnormal, and you eventually have a better intuition for what normal is over time.
All right. I think that's all the questions that I had. So thank you so much, Brandon, for taking the time to chat. That was cool. I felt like I learned a lot about, which is unique and different from mine and different from everyone's. It's always interesting to learn more about that. So.
Yeah, absolutely. And I'm by no means saying that, this is the best method for studying. It works for me, and it may not work for other people, but that's kind of what I'm to say. Thanks a lot also for having me on your channel, and it looks like you're doing some pretty cool stuff.
Thanks everyone. Bye. Subscribe to the channel, like this video if you liked it.
Bye folks.